welcome once again to Senior Focus. I'm your host, Bill Adams. Senior Focus is a show designed for adults over the age of about 50, and we bring to you guests a couple times a month who will talk about services and programs in the area and things that they do to serve older adults. Before we get started, I wanted to say thank you to Greg Roten, who is the producer of the show and brings it to you on Armstrong 20 and 100. If you happen to miss any of the shows, you can always go to On Demand. And also, Greg puts them up on YouTube, so you can check YouTube eventually. Also, thank you to the Canfield Library, where we're at today in the library system, for allowing us to use their beautiful meeting room. Today, we're going to be talking with Dr. Charles Wilkins. Dr. Wilkins is a geriatrician, geriatric specialist, and he's through the Mercy Health System.
Correct.
Thanks for coming.
Thank you very much, Bill.
It's been a while, but you've been on before.
About 4 years.
Yeah.
Yeah, we spoke on Alzheimer's disease.
Mm-hmm. And I was hoping we could talk about that again a little bit, but I thought we'd get started just sort of talking about your background and where you come from and how you get started in the field.
Okay, well, I'm from the area, born and raised in Youngstown, finished up at South High School, had an interest in chemistry, and went to the University of Cincinnati for training there, but then I found my interest was really in people, and so I got into medical school in Cincinnati, finished up, and missed Youngstown after 8 years and decided to come back. And did my residency training at St. Elizabeth's, and I went into practice. One of my first jobs was at the Mahoning County Nursing Home.
Oh, okay.
Yeah, and,
was that on Kirk?
Yeah, on Kirk.
Okay.
And I was lost in the wilderness, so to speak. I learned a lot in internal medicine and realized a lot of the patients there were frail and elderly, and realized I needed to bone up a little more. So then after a year in learning and helping people, I went on to Scotland for some further training with Professor Francis Caird at the University of Glasgow. At that time, Scotland was #1 in the world for geriatrics. It was the birthplace of geriatrics.
Is that right?
It probably still is. And so I had an eye-opening experience over there. Met Dr. Knight, who's come to Youngstown for the last 30 years.
Right.
Every year as a visiting professor, and we set up the geriatric program at St. E's. And
So
been there ever since.
What year was that approximately?
I came back in 1983.
Okay.
So it's been quite a few years. And not realizing at the time, actually, that Youngstown was in for a geriatric explosion of patients because of the loss of the steel mills in industry. And I experienced that in Glasgow in '83. That was a badly hit city with economics.
Yeah.
And the geriatric situation was the top percentage in the world as far as elderly people. And when I came back to Youngstown, it turned out the same statistics after a few years here, with our losses of the sheet and tube, and Republic Steel, and all the other industries. So it turns out the geriatric thrives in an economically deprived area as far as patients.
Yeah, I guess that's a factor of people, young people leaving.
Right.
And, the older folks probably, didn't really have that opportunity.
Exactly, and they've stayed in their community, in their old home, and it has implications for caregivers. A lot of times the families are out of town. Of course, that's not always the case.
Right.
And I enjoy the fact that in Scotland I learned a lot about the art of house calls.
Oh, okay.
And so it was kind of lost in our country, so I enjoyed going out into the homes of the elderly with a geriatrician and learning about how to intervene before they get particularly sick and have to go into a hospital.
Right.
And that was a very nice part of the training.
Well, that's really important, all the way up till today, and I know you still do that. I mean, on occasion, you do the house calls.
Yes.
When you think about, again, just public policy, we're trying to maximize the time people spend at home, because once a person goes into a long-term care facility, then the cost really goes up.
It goes up exponentially.
Right.
Of course, at home, too, if you need 24-hour care, it's comparable.
Sure, sure,
you know, but in the meantime, it's economical to keep people at home. as
Yeah,
long as possible.
the more you can keep them healthy,
Healthy,
relatively healthy. Yeah.
Mobile, functioning. In fact, elderly people prefer being in their homes if they can.
Sure,
And
yeah.
of course, that's not always possible.
Did I read somewhere, and maybe I'm wrong, but I thought I read that you were involved in some of the daycare, adult daycare openings?
Yes, when I was in Scotland, I noticed that the British had an operation called a day hospital, which involved bringing elderly in from their homes. And in certain day hospitals, they do therapy, but it was also for social situations too. And it helped the elderly split the core, they met others, and in the meantime, they had therapy. There were also daycare centers in Scotland that were called psychogeriatric daycare centers, which were for Alzheimer's.
Okay, yeah.
And we didn't have anything like that in our community. So when I came back, I recognized the need, and that was one of the first things I tried to set up. And it was hard at that time because the funds aren't available, you know, and they weren't
Right.
available. That's a long time ago, and they probably still aren't available.
Yeah, yeah.
So that's how I got started on. And that was about 1985. We bought a church on the west side. And why the west side? The west side of Youngstown happens to be the total dense area where elderly people reside at that time.
Wow, okay.
So it was not too far from Calvary Cemetery. And we converted it into a daycare center and rehab and a place they could eat and enjoy themselves. And then I had my office on the other side.
Oh, yeah?
Yeah.
Oh,
So it was kind of a combined situation, but it was difficult after a number of years economically, so we closed the center. But at that point, it spawned other centers throughout the community.
right. I think, we've just passed, last year, we passed the new, or this spring, actually, the senior levy.
Right.
And I know that part of the funds for that will go towards adult day programs, so
Right.
similar to what you started.
We have a number of those centers in the community now. So.
Yeah, you brought up Professor Knight, and he's been a longtime friend.
Yes, he has.
And he was actually, I remember he was on the show here, and that was a great opportunity to talk with him. You still see him, right?
Yeah, he was just here in September. He brought his dear wife, Margaret's retired nurse, and I said, "Why did Margaret want to come this time?" She said, "Well, she remembered the Canfield Fair, and that's all she's been talking about is the Canfield Fair."
Oh, yeah?
So he enjoyed himself at least one day at the Canfield Fair and did some teaching at the Youngstown University to the therapy students in geriatrics, and at the hospital. We had him on several house calls with us, and because that's where I learned about house calls. So-
Right. Is he still doing that in Glasgow? He's still?
No, he's cut way back.
Okay.
I didn't realize it. Well, I did know that, but 60 is the retirement age. So
Oh,
he turned 60, so now he's semi-retired. So he does a lot of hospital work, and he does a lot of teaching yet.
Okay, yeah,
But he doesn't do as much of the house call work that he did in the past. So.
right. Now, on your house calls, you were bringing students with you?
We bring students,
Residents?
we bring residents, and it's an important teaching experience for them. After the house call, they learn about the environment of the patient, the interaction with the family, review of the medications, other features that we can check in the house with the patient's physical exam. It's a little different, and kind of sum it up and come up with a plan and hopefully keep people in their homes as long as possible. These are patients that maybe would be more frail, trouble getting in a car, maybe it would be disruptive to bring it into an office or hospital setting.
Okay.
So they're usually our frailest people.
Well, yeah, what's interesting about that is you see them, again, in their own home, in the environment. And, you could tell, what their needs are, but what their strengths are too, what, I guess, the deficits in the.
Yeah, you can see from just the location, how the steps look. You're doing things that automatically you don't realize. Maybe there's a bad odor. Maybe you've noticed there might have been a fire on the stove recently. You may look at the flooring in the house. You're doing things indirectly you don't realize. And you have a mental image that lasts for quite a while.
Sure.
I have a student now who we made some house calls 25 years ago. He's an Ohio U student. He's the physician now. He said, I remember those house calls, and he had so much detail recalled from 25 years ago.
Is that right?
And I said, I can't get over it. I said, well, what you see in that experience stays with you a long time. At one point, I was going to document all these house calls with pictures and things. And,
Yeah.
and we would call it a home marrow instead of a bone marrow, a home marrow. Bring the pictures in and show, oh, this is their favorite hobby. I didn't know they liked gardening. I didn't know they liked the ham radio. Just different things that would just spice it up. So this is a real person we're treating.
And part of it too, I know we talked on the phone a bit, is also helpful for some of the residents who are not from this area.
Right.
You were talking about how, you were telling people about some of the foods of the area and some of the traditions and culture. And
Yeah, we would learn about baklava or kolache or halushki. And I remember one house call, the daughter had such an interest in that, she made the residents and me as plate as halushki. I said, what is this stuff? In fact, it was a house call on camel once. So, and there have been other situations they'd never seen. Some of them have never seen pizzelles.
is that right?
Or never heard of wedding soup.
Well, they've been
So
denied.
they get a cultural experience for the area, so
Sure.
it's quite good.
Now, these are the physicians or the residents that are now at Mercy? Through the
Yes,
Mercy
they are the
system.
Mercy System residents.
Yeah.
Yes, indeed.
And so your office, I guess we haven't mentioned that, but you're actually at the Mercy, at the hospital?
At
or
the
just-
hospital,
okay.
close to where the old nursing school was, across the street on Belmont Avenue.
Okay,
And that was torn down, and there's a family health center there. So
Right.
we're right in the family health center, our offices.
okay. How many other geriatricians or geriatric specialists are there in Youngstown area?
There are, as we had mentioned one other time, board-certified geriatrics. You can go through internal medicine and family medicine to become board-certified. There's probably at least 3 or 4 of them in the area.
Okay.
As far as fellowship trained, there's not too many at all, really. Yeah, very few. Just myself, I think.
What about the Neo-UCOM? Is that what it's still called now, the Northeast Ohio?
Neomed.
Neomed, I'm sorry, yeah,
I
Neomed.
still call it Neo.
Yeah,
It's Neomed.
we're used to that.
To most of us, yeah.
But do they have a specific training for geriatrics?
Yeah, they do. In their first years, they have geriatric training. And then sometimes I'll see a student on my service that would be taking a geriatric rotation, not to all the students. And when they do internal medicine, if I'm doing ward rounds, we teach them a lot about geriatrics, seeing our frailest patients on ward rounds. Teach them about acute confusion or the mobility issues or continence, medication differences, different things like that, psychosocial things going on.
Right. I think one of the difficulties with geriatrics, I would imagine, is just the financial incentive. Again, I don't understand this. Maybe you could explain a little bit, but like under Medicare, Medicaid, or insurances, as a doctor, they don't want you going in for, unlimited talk or discussion with patients. I think there's a pressure,
Right.
isn't there?
There is a pressure to see more patients in less time.
Right.
And all the primary doctors are under that pressure in the community. Geriatrics is usually a little different. We're subsidized by a hospital or other party.
Okay.
So we can see fewer, and really that's our specialty, to spend more time and try to determine what the real issues are. They're very complex. So
Right.
we may have to spend more time, so we're subsidized differently.
Well, that's good. And I just thought of a question or some suggestions maybe. If people are out there and their spouse, has some needs, or, they're a child of an older adult, and they go in to see a doctor, can you give some tips on how they can best interact with the doctor and help the doctor, in terms of providing information?
A lot of times if they come in with their loved one, it's hard to talk in front of that person. There's a defensive situation, and you may want to write things down clearly what their concerns are, and I call them like an epistle. I get the epistle, and that's an important part of our record, and we can determine, you know, as good as Mom says she's doing, she's fallen 3 times this week. You'll see the bruise over here and there or whatever, or there's an incontinence problem, or she's not eating well, or different things they have concern. She's getting more confused at night, and was locked out of the house once. So those things you can't necessarily talk in front of the patient. Sometimes writing these things down is important. Sometimes there's a time when we may have to call them outside of office hours and get more of this information in a protected time where they're not overheard on the phone and things like that. So.
Right. Yeah, I can almost imagine the scene where, you know, you're sitting there with the older adult, and maybe behind the adult there's somebody waving their hands. You're saying, no, that's
exactly. That comes up all the time. And it's, in a way, it's sort of like, I tell the residents, like pediatrics. I don't want to demean older people, but if a 3 or 4-year-old came in and you took the history from them and examined them and completed your workup, don't you feel like you may want to talk to the mother? Oh, yeah, that's natural.
Sure.
So it works the other way, but again, not to demean an older person. That's important in their treatment.
Well, I think one of the concerns, you know, I'm putting myself in the shoes of somebody who's in their 80s or 90s and living independently at home. You're probably fearful that somebody's going to take my independence away.
Absolutely.
So I want to, you know, show that I'm independent as long as possible.
Exactly. They want to stay independent as long as possible. I'll give you an example. Well, we'll feel better if Mom has a first alert. She'll go down on the floor and ask for help through the button.
Right.
Well, I always say, I don't think she'll push the button. She'll try everything possible to get up before she pushes the button. So, and they'll say, why didn't you push the button? I didn't want to bother you. So that's just one example. But you're right.
Sure.
And if you put yourself in that position, you don't want to seem frail or incompetent. You want to maintain independence. It's an important human trait. So you have to respect that.
What are some of the, you know, obviously you spent, you know, your career in this field. What is it about geriatrics or working with older adults that's really inspired you or give, you know, makes you want to come in every day?
Oh, just everything's so different every day. There's no set game plan to each case. The rules, sometimes you can go through rules. There's a list called Beer's List for drugs you shouldn't use in elderly. And sometimes you use one that's an outlier, you know, or you might find that after you kind of put things together, you find a little problem that's making the whole thing collapse. Maybe a woman has a foot drop or something and falling. And the main thing is they get through this, and people generally turn out to do a lot better. They don't necessarily return to normal, but they do a lot better with your interventions. And that's important to me, and I like that.
Yeah.
Yeah, I see improvement that way.
Yeah, and I think, you know, that comes through, and again, just the way you were talking, and I guess that's what you're trying to impart to maybe some younger doctors who are, you know, I would think it's not as, is the word sexy? You know, for a doctor to go into geriatrics.
It isn't, no, it isn't really that, but it's just the things that are important. Well, you know, you feel so good about helping people that way, and you do. I mean, not necessarily, sometimes they swipe you down, but and you take it like a man and then come back another direction. But again, it's just a very gratifying field for me, and I try to inspire the residents and students that same way.
Right. And before, you know, I don't want to go all the way through the program, but before forgetting that you were actually just awarded through the Medical Society in Mahoning County Physician of the Year, is that correct?
Right.
Talk a little bit about that, if you would.
Well, every year they nominate and elect a person to receive the award. It's called the Distinguished Award, Physician of the Year, and through the Mahoning County Medical Society. And I was voted on and elected to be that person this year, and I was very honored to have that award.
Sure.
It had a lot to do with Dr. Abdu, but he'd known me for a long time, even since my residency. So he thought I should be honored, and I felt honored to receive the honor.
Sure, yeah, and Dr. Abdu's been on the program and has done great work. But you know, when you think about again, there are several hundred physicians, I think, in the county.
Exactly.
So that is a great honor. Congratulations.
Thank you very much.
Also, you know, the reason I thought about that is on Facebook, the local Alzheimer's network, and we've had Dorothy Bartow on. They gave you a plaque to honor that. But also, you're going to be speaking, let me make sure I have the date, November 5th.
Correct.
And that's at Sunrise over in Boardman, which is assisted living. But that's going to be about Alzheimer's, I think,
It
right?
will be all about Alzheimer's, and what I like to do every year is try to bring people to the realization there's research going on and there's some hope. It's been pretty grim the last 2 or 3 decades.
Sure.
So I try to bring research that may have more hope in the next few years. There may be a new drug that might give some help to the family members or other issues. These are all caregivers, and they have a lot of questions and issues with their loved ones. It's a very bewildering disease to be a caregiver for.
So, in that vein, if somebody is new, comes in and, they're there with their loved one and the loved one is exhibiting Alzheimer's symptoms, what are some of the things that you discuss with people up front early on in the process?
Well, realizing after we've diagnosed it, a lot of times it's not easy to diagnose. And as you had mentioned once in the program, we can't do a brain biopsy on everybody or an autopsy. So we have a fairly good idea a person has a dementia, and most of the dementias are Alzheimer's. The difference is Alzheimer's progresses year to year. And with the right interventions and paying attention to their medical problems, in particular, treating maybe underlying depression too, which often is there, getting the medicines correct, we can delay the demise of the patient for some years, and prevent or delay nursing home care, and help the caregiver. Really, what we do for the patient helps the caregiver.
And again, that helps both the individual, the patient themselves,
Exactly.
the caregiver, but again, society, if you delay expensive care because the person is higher functioning longer.
Yeah, we can hopefully with some of the medicines keep them functioning longer at a better level. That's the main thing. The medicines of the future will actually stop the disease or potentially reverse it. That's what we're looking forward to hearing about.
Now, I remember that the University of Pittsburgh is one of the local research centers, Cleveland probably.
Cleveland as well, and they're researching new drugs all the time. And basically, there have been some new drugs that they're talking about now, but again, I'll wait till November 5th to divulge all that.
Yeah, so again, that's going to be at Sunrise Assisted Living. Contact them in Poland. But, one thing when we were talking, and I'm glad what you mentioned about doing a sort of a full exam at the beginning, or looking at, things like medication. I think people might say, well, someone has Alzheimer's, but it could be an underlying medical condition or the use of a medication.
Sometimes a medicine in someone over age 80 could work just the opposite on their brain, have unusual side effects, and we have to look at the medicines they take for their heart or their lungs or diabetes and kind of decide if that's interacting well with their brain if there's dementia.
Right.
And sometimes altering the medicine or working with the family doctor can make a big difference. So getting them as healthy as possible medically first.
Right.
And then dealing with the dementia next. And then helping the caregiver is the main thing, and keeping them at home if it's feasible, and it usually is.
Right. The other, you used the word depression, or you mentioned depression, and I think, just in my opinion, from what I've read, that's really an underreported or undertreated maybe situation with a lot of older adults.
It's very common in elderly people, depression, and indeed it's, as well as that, it's often part of the Alzheimer's patient too. They have depression as well.
Right. And so they're dealing with, the illness and maybe isolation or the feeling, depression.
And it's not always, depression is not always a medication will help it. It's because of some of the losses they've experienced.
Right.
Maybe bereavement.
Sure, if
Maybe loss of their vision or their hearing or loss of their independence. And so it can't always be treated with a medication, but we can help counsel them on these other things and try to make it better in some way.
Have you found, we only have a couple minutes left, but activity for seniors, I mean, obviously, you know, we're not going to maybe be able to run a marathon when we're 85 or 90, but just some physical activity, does that help both mental and physical?
It really does. Physical activity is underutilized. The simplest thing is walking or swimming.
Sure.
Aerobic exercise helps the brain, it helps the body, it helps the balance, it helps the bones, it helps the metabolism. It's just great if we can keep that going.
Sure. And again, you know, that's where something like an adult daycare or a senior center.
Exactly.
Or, you know, it just, you know, you could do this at home too.
Yeah.
But I mean, you know, like you said, walking, if somebody can get out and walk down the end of the block, you know, and back, that's excellent.
It's beautiful.
Yeah. Again, we're talking with Dr. Charles Wilkins. We have a minute or so to go. Again, your headquartered or your office is at Belmont
Avenue, 1053 Belmont, phone number 330-480-2516.
And you have no plans for retirement, right?
No.
We were talking a little bit before the show.
We have.
Yeah.
But not at the moment.
Fortunately, we don't live, well, you know, again, there's some reasons why it'd be good to live in Scotland.
Yeah.
Certainly the views. You've been there. But you don't have a 60 age limit here.
No, not at all.
Like they do over there. And speaking of which, do you plan on seeing Dr. Knight again, or are you going to?
He's going to be back next year in May. We've already set it up.
Well, that's good. Well, yeah. Anything else you want to let people know about?
Well, I think getting older, if we're lucky, we all can get older. I never say old because it's derogatory itself, that name. So
Sure.
say older. And it's okay to get older. And we'll deal with the problems as we go on and try to make it the best we can and enjoy our life as long as we can.
Sure. Well, again, thank you, Doctor, for 3 or 4 decades now of service to Mahoning Valley residents and allowing people to age with dignity and better health.
Thank you, Bill.
Thanks.
Okay.
Again, you've been watching Senior Focus. I'm your host, Bill Adams. Thank you to Greg Roten from Armstrong Channel 20 and 100 for bringing the show to you. And also thanks to the Canfield Library for the use of their meeting room. Until next time, thank you for watching.
All they want is a chance to be loved, to be your companion, to stand by your side. And what do they ask in return? Just a little love from you. Consider adopting a shelter pet from one of the great organizations in the Mahoning Valley. Proudly sponsored by Armstrong Positively Pets. Adopt a shelter pet, a friend for life.
The history, the sports, the stories, the events. Armstrong Local Programming puts the focus on our community. Watch to learn about new events or discover the rich history of our area. You can find local programming on your local programming channel and on demand. Want even more? Subscribe to the Armstrong One Wire channel on YouTube. It's our town all the time with Armstrong Local Programming. One Wire, infinite possibilities.